Now let's go into STEMI and then we'll make our way back to the stress test and the hard cath. Now, the worst possible outcome for your patient when they present to you with chest pain is, could they have a STEMI? Obviously, if the patient has got a STEMI, what are you going to look for? You will see ST segment elevation. ST segment elevation is going to be present. Now, by how much should it be elevated? If it's your limb leads, which is 1, 2, AVL, AVR and 3, right? It should be elevated by 1 millimeter. And if it's your chest leads, it's going to be 2 millimeters. And typically you need to have 2 contiguous leads for you to call it a STEMI. And if the STEMI is present, immediately at that point, what are you going to do? Activate a STEMI code, right? You activate a STEMI code and the cardiologist obviously going to come running downstairs. This is their moment, right? This is what they've been waiting for. This is their golden moment to be heroes, right? So they're going to come. What are they going to do? They're going to take the patient to cath. So, important question is, how soon should their door to needle time be? 90 minutes. That's going to be your board question. 90 minutes. Again, we are internal medicine, not cardiology. So you don't have to go so crazy on this part. What you need to know is basic things. So 90 minutes is your door to needle time, right? Now, when they go to the cath lab, are they going to give this patient the same medicines that we just gave? Because we don't see STEMI that often because it goes from the ER directly to the cardiologist. Yes, you are going to load them with aspirin. You are going to load them with a P2Y12 drug. You are going to give them anticoagulation full dose, typically going to be heparin. Sometimes you'll also see that they might use a drug that works on your GP2B3A receptors, such as abciximab, tirofiban or eptifibatide. So your GP2B3A drugs are going to be used in the cath lab by the cardiologist while they're doing this procedure. Okay? But all of them, they're going to load the same drugs that you did in the ER, but they're going to do it in the cath lab on this patient because for them, it's really bad now. That is STEMI. So there's a large area of the myocardium getting affected, so they've got to fix this now before the myocardial cell is dead. Right? So door to needle time is 90 minutes. Now, say you guys graduate from here and say, you know what, I'm done being here, I want to go to some other hospital, and you unfortunately go to some remote location because they paid you a little bit better, and guess what, they don't have cath lab there. No cath lab. Okay. Now you got a chest pain, the patient's got a STEMI, and you're in the ED. What are you going to do? TPA. Okay, so the big question for you is, do you have a nearby hospital? Do you have a nearby hospital with a cath lab? When I say nearby, how much time?
120 minutes.
Very good. Your magic number is going to be 120 minutes before you reach a hospital with the cath lab. If it is present, what do? Transfer them out. Say you said, okay, you know what? I want to go even more remote. No neighboring hospital at all. Okay? Now, if the patient presents you with a STEMI, what are you going to do now? You will give them TPA. You will give them TPA. Now, typically TPA can be given up to how many hours from your STEMI? About 6 to 12 hours max. Within 6 to 12 hours max. The maximal effect of a TPA in this situation happens within the first 3 to 6 hours. After 6 hours, your effectivity dies down. Okay? You give TPA because the patient is too far out, you can't get to a cath lab within 120 minutes. Say you give TPA. Are you still going to transfer this patient and you're saying, no, I'm going to keep the patient here, we're good? No. Always transfer. Always transfer after you have given TPA. May the patient have unstable angina, non-STEMI or STEMI. End result, say the patient ended up getting a cardiac cath. You did a cath and the patient gets a 1, 2 or 3 stents. Important thing is not how many stents you received, but did you receive stents or not. Just because you got 3 stents doesn't change how long you treat with antiplatelet agent. The moment somebody gets a stent, important question is, what kind of stent did you use? Is it a bare metal stent or is it a drug-eluting stent? Now, pretty much nowadays all we use is drug-eluting stent. You barely ever use a bare metal stent because it doesn't remain patent for that long, right? So when you do a drug-eluting stent, how long should you do dual antiplatelet therapy for? It's always been up to 1 year or even longer, but what is the minimum duration?
6 months.
6 months. At least 6 months you want them to have dual antiplatelet therapy, and typically you want to go at least to 1 year. Can you use it longer than a year? Yes, you can use it to a year, 2 years, 3 years, doesn't matter, you can keep going. Important thing is, as long as the patient is not bleeding, you can go longer. The big board question is, what is the shortest duration they must be on it? And that answer is 6 months. Now, bare metal stent, how long do we need it for?
30 days.
1 month. That's it. Okay? Now, is there a world if a patient is a high risk of bleeding? We have a lot of patients who are very high risk of bleeding, right? Is there a world where we can get away with just 3 months? The question is, if somebody is on Eliquis, right, and if the patient is on triple therapy, say you have AFib, Eliquis, and a stent, and you're on DAP, right, aspirin and Plavix. When you want to drop a single agent, you typically drop aspirin and you continue anticoagulation plus the second agent, P2Y12 is what you continue, which is clopidogrel. Imagine your patient has a massive MI, and typically most of the time these complications are going to happen in a patient who has a massive infarct affecting multiple large areas of your heart. Okay? If you have a massive MI, you're going to have complications because of that MI. So what are some of the complications that's going to happen? Within the first hours when patient is having MI, what is the most important complication you worry about initially? Imagine if there's decreased blood flow to your myocardium and there's cell death. You want to release a lot of potassium, right? Because there's a lot of potassium within cells. If you have a lot of potassium and all this acidosis happening, what is that going to lead to? Arrhythmias. You're going to get a lot of arrhythmias. So within the first days, first hours, you're going to worry about arrhythmias happening in your post-STEMI patients. And typically, what kind of arrhythmias would you expect? You do see a lot of AFib. But apart from that, typically you'll see ventricular tachycardia and VFib. And these are very notorious to happen in less than 48 hours. The first 48 hours is when it's going to be happening most of the time. So arrhythmias, again, if you go and do the heart cath and fix the problem, this arrhythmias typically will stop. It's happening due to hypoperfusion. So remember this, arrhythmias are going to happen. Now, if it is persistent for more than 48 hours, then you may consider putting a device in this patient such as an AICD. Because now it is more persistent even after you have revascularized them, and it's persistent after 48 hours. Especially if it's a VTAC or a VFib, not for AFib. If it's a VTAC or VFib, if it is persistent after 48 hours, those patients you can consider an AICD. So one of the most common complication you're going to look for is going to be arrhythmias. Okay? Alright, what else can happen if a patient has a massive STEMI? Imagine the patient had a right ventricular infarct. Okay? If a patient had a right ventricular infarct, let me ask you another question. If you're suspecting a patient to have a right ventricular infarction, what specific EKG findings are you looking for? Because typically, you put your chest leads on the left side. You go from V1 to V6. Would you do anything different if you're looking for a right ventricular infarct? You would reverse it. You would reverse it and you would go in this direction, and typically you'll say EKG changes affecting your V right, V4 and your V1. In order for you to diagnose it, you'll see ST segment elevations in V1 lead and reverse V4 or right V4. Okay? And if it's present, then you will diagnose your right ventricular infarct. So if somebody's got a right ventricular infarct, what do you worry about? Your right ventricle cannot function. So these patients can actually undergo hypotension. You can have a complication in right ventricular infarcts, develop hypotension, and therefore these patients is where you should not give them nitroglycerine. Instead, in an acute MI setting, which is unusual, normally you don't do it, but what would you give them instead?
Fluids.
IV fluids. Why? Because if your right ventricle is affected, you are not going to be able to pump blood from your right ventricular chamber into your left side. So typically, you will have an elevated JVD, right? Because your right side is what is getting stunned, and your right atrium is going to go to your IJ. But you're not going to pump blood to your lungs, so your lungs are going to be clear. Okay, so when you have a right ventricular infarction, you're going to have clear lungs because you're not pumping blood to your lungs, right? But at the same time, you're going to have hypotension on this side, and the patient can go into cardiogenic shock because of it. Okay, so you should always think about a right ventricular infarction if you have a pattern of elevated JVD, clear lungs, and if the patient got nitroglycerin, became hypotensive, and the patient is in shock. Alright? Okay, so what about the left side? What if your left anterior ventricular wall has a massive MI? What's going to happen? You can go into cardiogenic shock. You can go into cardiogenic shock because the large part of your ventricular muscle is now dead and therefore you cannot pump blood out, so everything's going to back up. But here, when it's cardiogenic shock, you will have acute pulmonary edema. That's going to happen. And apart from that, the patient's going to have decreased blood flow outside, and therefore patient is going to be in a state of shock. And the shock is essentially going to lead to what? Multi-organ failure. You'll level up AKI, you'll have mesenteric ischemia, right? You can have hypoperfusion to the brain. So all of those problems are going to be present. So if somebody's got a cardiogenic shock, how are you going to treat them? Fine, you can have a cardiogenic shock, but sometimes if this ventricular wall is really dead, you can have a ventricular wall rupture. If your ventricular wall rupture, what are going to happen? What's going to happen then? Pericardial effusion. It is called pericarditis. But when you think of this pericarditis, it is going to be called what syndrome?
Dressler.
Dressler's syndrome. Okay. Now, whenever you suspect a patient with pericarditis, the symptoms are going to be very classic. What is the symptom they come with? They come with chest pain, but it's going to be pleuritic, right? And the chest pain typically improves when you lean forward. Okay, so you want to have that history, and typically when you see pericarditis, you get an EKG. And the EKG, what do you typically see? What is your most sensitive finding for pericarditis? You'll see a diffuse ST segment elevation. And here, is it going to be convex or concave? It's going to be concave, unlike your STEMI patients. But is this is your most sensitive finding, but what is your most specific finding? It is PR depression. Very good. It is PR depression. Now, would you have elevated troponin in a patient with pericarditis? You don't always have to have it, because you don't have troponin in your pericardium, you have troponin in your myocardium. A lot of times when patients have pericarditis, viral or whatever it is, you tend to get a myopericarditis. So you will have myocardial damage to release troponin. Now, I'm not talking about your classic pericarditis, right? Because classic is viral or something autoimmune causing. I'm talking here post-MI pericarditis. Are you going to see these EKG changes?
Maybe not.
Maybe not. Why not? Because this patient most likely came with a STEMI, right? And if the patient came with a STEMI, you will probably have STEMI changes on this patient. Yes, if somebody comes with a STEMI and you do a hard cath and you fix the problem, do you expect those EKG changes to improve? Yes, you do expect it to improve, but do you expect it to improve all the way? No. You expect a 20 to 40% improvement from what you saw before. And in fact, everybody who gets a STEMI, once the stents are done, you're supposed to repeat EKG to look for the changes to have improved. So you will almost expect these patients post-STEMI are going to have some residual changes, and therefore your classic EKG changes might be hidden or may not be as pronounced. Okay, that's going to be important. So once you suspect pericarditis, EKG, troponin, typically you'll get echocardiogram. What you're looking for is pericardial effusion, right? Now sometimes you get an X-ray, you can see some pericardial effusion on the X-ray too. But important thing is for you to identify and diagnose Dressler syndrome. Happens weeks after. It happens because of an autoimmune philosophy. You're expressing antigens from your cardiac myocyte that the body is not normally used to, and now it's going to go and attack it. Now, how do you treat it? Thank you for watching. If you like our content, please like this video, subscribe to our channel, and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.